Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, we will be discussing a very important topic in the respiratory system, that is the pneumonia. So first of all, you need to understand what exactly is the definition of the pneumonia. So pneumonia, it is an inflammatory condition of the lung. Right, and this inflammatory condition of the lung is secondary to the infectious pathologies. Right, it is the inflammatory condition of the lung secondary to infectious pathologies, and this particular pneumonias, it mainly affects the microscopic air sacs, that is the alveoli. Right, so mainly the alveoli are being affected in this pneumonias. And how do these pneumonias present? They present with fever and as well as cough. These are the very important symptoms of the pneumonias. And this pneumonia is mainly secondary to infection. And this infection, it could be either a bacterial infection, viral infection, or a fungal infection, or it could be a parasitic infection. Okay, so that is what is the basic definition of the pneumonia, right, where it is an inflammatory condition of the lung, especially affecting the microscopic air sacs associated with fever, chest symptoms and lack of the air space on the chest x-ray. So in the chest x-ray, what is that you will have? The presence of consolidation. Okay, so this is the definition of the pneumonias. Now let me just tell you the classification of pneumonia. See, pneumonias, they are being classified by various ways. One is anatomical classification. Second classification of pneumonia is from where the organism has been acquired to the individual. And then we have primary and as well as the secondary pneumonias. So first of all, let me take up the discussion of the anatomical classification. So pneumonia anatomically, it is classified as the airspace pneumonia and as well as the interstitial pneumonia. Because if you take the lung, what does the lung contain? That is lung parenchyma, that is alveoli and as well as the interstitium. So if it is the inflammation of the airspace, that is alveoli, that will be your airspace pneumonia, and if it is inflammation of the interstitium, that will be the interstitial pneumonia. And this airspace pneumonia, again it is classified into lobar pneumonia and as well as the bronchopneumonia. So this is what is your airspace pneumonia. Now let me take up the discussion of the lobar pneumonia, or let me show you all the types of pneumonias first. So if you observe this lobar pneumonia, in case of lobar pneumonia, it is the lobe of the lung, right, which is inflamed and as well as infected. It is the lobe of the lung which gets consolidated, as the name itself tells you. So that will be your lobar pneumonia. Whereas the second one is the bronchopneumonia. See, in case of bronchopneumonia, the consolidation is not confined to one particular lobe. The consolidation, right, it is distributed throughout the lung. That is what is your bronchopneumonia, right? It is not confined to one lobe like what we see in lobar pneumonia, right? The consolidation is confined throughout the lung. It is distributed throughout the lung. Then if you take the interstitial pneumonia, in case of interstitial pneumonia, it is the interstitium of the lung, right? It is the interstitium of the lung which is infected and as well as inflamed in the patients with the interstitial pneumonia, and because of which you have the presence of the honeycombing and fibrosis affecting both the lung bases. Okay, so this is your anatomical classification of pneumonia. Now first let me take up the discussion of lobar pneumonia in detail. So most common causative organism for lobar pneumonia is Staphylococcus aureus, Streptococcus pyogenes, Streptococcus pneumonia, Haemophilus, influenza. So the answer to this question is the Streptococcus pneumonia. This is the most common causative organism for the lobar pneumonia. And how will be the presentation of the lobar pneumonia? Let me just show you. Right, so if you see the features of lobar pneumonia, please remember that large areas of the lung or entire lobes are consolidated. Okay, large areas of the lung or entire lobe of the lung, right, it is being consolidated. So you can observe that here, right, it is mainly the upper lobe of the lung is consolidated. And you have to remember that in case of airspace pneumonia, bronchi, they are not involved, right, bronchi, they are not involved in case of the lobar pneumonia. And the chest x-ray, it will show you the presence of consolidation. There is large areas of consolidation, right, large areas of consolidation. And in this consolidated lung, what is that you will observe? You will have the presence of air bronchograms. So what do you understand by this word air bronchograms? Air bronchograms are those where you have the presence of air and as well as the alveolar fluid, right? So if you take, this is the alveoli, okay, and this will be the fluid and this will be the air. This is what is called as the air bronchograms, okay. And the most common organism causing lobar pneumonia will be Streptococcus pneumonia. Right, it will be Streptococcus pneumonia. So this is about your lobar pneumonia. Now, having discussed about the lobar pneumonia, right, there is one clinical entity called as pneumatocele. Pneumatocele is caused by Streptococcus pneumonia, Haemophilus influenza, Serratia marcescens, Klebsiella pneumonia. Let me tell you, pneumatocele is the condition which is caused by Streptococcus pneumonia. Now, you should also know what you understand by this word, the pneumatocele. The word pneuma is nothing but air. So, pulmonary pneumatoceles, they are thin-walled, air-filled cysts, right? You can observe that here, right? These are thin-walled, air-filled cysts, right? Thin-walled, air-filled cysts. And they develop within the lung parenchyma, right? They develop within the lung parenchyma, right? And these air-filled cysts, they are multiple in number, right? They are multiple thin-walled air-filled cyst-like cavities. That will be your pneumatocele, and that is caused by your Streptococcus pneumonia. And please remember, this pneumatocele, it occurs as a sequelae to acute pneumonia, right? It occurs as a sequelae to acute pneumonia. Okay, so that is what is your the pneumatocele. And this pneumatocele is not only caused by the Streptococcus pneumonia, it is also most commonly caused by Staphylococcus aureus, right? It is also caused by Staphylococcus aureus. And not only Staphylococcus aureus, even Streptococcus pneumonia will also cause this particular pneumatocele. If you see the next question, most common pattern of pneumonia seen in Klebsiella infection, lobar pneumonia, bronchopneumonia, interstitial pneumonia, miliary pneumonia. Let me tell you, Klebsiella pneumonia, it will cause lobar type of pneumonia. So, the organisms causing lobar pneumonia are number 1, Streptococcus pneumonia. Number 2, your Klebsiella pneumonia. We will discuss that in detail again. Next, if you see the other question, all of the following statements about pneumococcal pneumonia are true except pneumococcal pneumonia is nothing but your Streptococcus pneumonia. The options are non-segmental consolidation, air bronchogram is absent, usually confined to one lobe, cavitation is rare. So the question is like, which is the incorrect statement? So let me tell you, the air bronchogram being absent is an incorrect statement about pneumococcal pneumonia. So pneumococcal pneumonia, it is the one which will cause the lobar pneumonia. Right, it is the one which will cause lobar pneumonia. So in this lobar pneumonia, you have the presence of air bronchograms. Right, you have the presence of the air bronchograms. That is what you will observe in the pneumococcal pneumonia, that is the Streptococcus pneumonia. And the consolidation, it is a non-segmental consolidation, usually confined to one lobe, and cavitation is rare. Now, let me discuss in detail about this pneumococcal pneumonia or Streptococcus pneumonia. Right, so please remember these 10 P's of the pneumococcal pneumonia. So you have to remember that pneumococcus or Streptococcus pneumonia, right, Streptococcus pneumonia, it is the most common organism causing community acquired pneumonia, or the most common organism causing lobar pneumonia. Okay, so 1P is your pneumococcus, most common organism causing community acquired pneumonia, and the next P is positive. What do you understand by this word positive? It is a gram positive cocci, right? It's a gram positive cocci. And another P is that if you observe under the microscope, you have paired appearance. I will show you the image subsequently, but remember you have this paired appearance when you observe this pneumococci under the microscope. And another P is pyrexia. So this pneumococcal pneumonia will cause pyrexia of high grade. Right, pyrexia of high grade. And another important P is this pneumococcus pneumonia or pneumococcal pneumonia will cause purulent rusty sputum. Right, the color of the sputum is purulent rusty sputum. And another important P is that, please remember, this Streptococcus pneumonia will not only cause lobar pneumonia, it can also cause pleural effusion. Then we call it as synpneumonic effusion. So due to which the individual can develop pleuritic chest pain. So pleuritic chest pain is the feature secondary to pleural effusion that you will have in patients with a Streptococcus pneumonia. So what is a complication? Common complication, that is pleural effusion. That is another P. Okay, so pleural effusion is another important complication of this Streptococcus pneumonia or pneumococcal pneumonia. And another important P is that it pretends, which one? The pneumococcal infection, it pretends as, right, it pretends as COPD, that is chronic obstructive pulmonary disease, or it pretends as congestive heart failure exacerbation, right, or it pretends as an acute abdomen as well. And if you take the another important P, there will be polymorpho nuclear leukocytosis, right, polymorphonuclear leukocytosis on the complete blood picture. And another important P is, it is penicillin sensitive. That will be the antibiotic of choice for your pneumococcal infection. So these are your 10 P's about your pneumococcal pneumonia, right? Now I said you they have the paired appearance, right? You see, this is the microscopic appearance of the pneumococcal pneumonia where you have the presence of the paired appearance. Now see, the most common community acquired pneumonia is pneumococcal pneumonia. So in order to prevent the development of this pneumococcal pneumonia, vaccines have been developed, and there are certain group of patients who should take these vaccines. Now what are those vaccines? We have two types of vaccines. Number one, pneumococcal polysaccharide vaccine, and the other one, second one is polysaccharide protein conjugate pneumococcal vaccine. So if you take the pneumococcal polysaccharide vaccine, pneumococcal polysaccharide vaccine consists of 23 most common capsular serotypes, right? 23 most common capsular serotypes. Okay, that is what is your pneumococcal polysaccharide vaccine. And this pneumococcal polysaccharide vaccine containing 23 most common capsular serotypes, they can cause invasive pneumococcal disease, right? It can cause invasive pneumococcal disease. Okay, so that is about your pneumococcal polysaccharide vaccine. Then if you take the second vaccine, that is polysaccharide protein conjugate pneumococcal vaccine. See, this particular vaccine, it is mainly used in children, right? Mainly used in children less than 2 years. Also used in adults of age more than 50 years. Right? Children less than 2 years and adults more than 50 years, right? They have to be given the second vaccine, that is polysaccharide protein conjugate pneumococcal vaccine. Now, in which group of individuals you need to give this particular vaccine? Indications. Indications of vaccine is that elderly individuals age more than 65 years, because in elderly individuals the immunity is reduced, so they are more prone for infections. So in order to prevent the infection by your pneumococcal pneumonia, you need to give these pneumococcal vaccines. And there are certain risk factors where, right, there are certain risk factors where you have to give this pneumococcal vaccine, like congestive heart failure, asthma and chronic obstructive pulmonary disease, diabetes mellitus, then in patients with chronic liver disease, next alcoholism, right, then followed by that splenectomized patients, right, splenectomized patients. So you have to know that in patients with sickle cell anemia, there will be autosplenectomy. So splenectomized patients, including patients with sickle cell anemia, you have to give this pneumococcal vaccine, right? And immunocompromised persons. So these are the group of individuals in whom you have to give the pneumococcal vaccine. Now, after having discussed about the pneumococcal pneumonia, let me discuss another important form of pneumonia, that is Friedlander's pneumonia. Friedlander's pneumonia refers to pneumonia caused by Klebsiella, pneumococcus, Haemophilus influenza, Staphylococcus. Remember, Friedlander's pneumonia refers to pneumonia caused by Klebsiella. So just now we have discussed even Klebsiella will also cause the Lobar pneumonia, right? Will also cause the Lobar pneumonia. Now let me take up the differences between the Lobar pneumonia caused by Klebsiella from the Lobar pneumonia caused by pneumococcal pneumonia. So you see a question here. All of the following are more commonly seen in Klebsiella pneumonia than in pneumococcal pneumonia except, right? So the question is like, which of the following is not very much suggestive of the Klebsiella pneumonia? Options are lower lobe involvement, abscess formation, pleural effusion, and as well as the cavitation. Now let me take up the differences between the pneumococcal pneumonia and as well as the Klebsiella pneumonia. You take the consolidation pattern. In both of them, you have the presence of lobar consolidation, right? And in both of them, you have the presence of the air bronchograms, right? You have the presence of air bronchograms. Whereas the very important difference is the lobe predilection. So if you take the lobe predilection, in case of pneumococcal pneumonia, predilection is mainly to involve the lower lobe. Right, predilection is mainly to involve the lower lobe. Okay, whereas in Klebsiella pneumonia, it commonly involves posterior segment of right upper lobe. Right, posterior segment of right upper lobe. So consolidation of the posterior segment of the right upper lobe, this is called as bulging fissure sign. Right, this is called as bulging fissure sign. That is what is the lobe predilection for Klebsiella. That is an important difference. Pneumococcal pneumonia, lower lobe involvement. Klebsiella pneumonia, right upper lobe involvement. Whereas if you take the abscess formation, in pneumococcal pneumonia, the abscess formation, it is uncommon. Whereas in Klebsiella pneumonia, abscess formation is more common than compared to that of strep. Right? So here, it is more common than compared to that of streptococcal pneumonia. Whereas pleural effusion, even the pleural effusion, it is uncommon. Right, it is uncommon in pneumococcal pneumonia, whereas it is common in Klebsiella pneumonia. Right, and this pleural effusion may even progress to the development of empyema. Right, may even progress to the development of empyema. Whereas cavitation, if you see, cavitation is rare in case of the pneumococcal pneumonia, whereas in Klebsiella pneumonia, the cavitation, it is common. Right, cavitation is common in Klebsiella pneumonia. So these are the differences between the lobar consolidation caused by your pneumococcal pneumonia and as well as the Klebsiella pneumonia. So going back to the question, all of the following are most commonly seen in Klebsiella pneumonia than in pneumococcal pneumonia, except, what is the answer here now? Lower lobe involvement. So you will not have lower lobe involvement in Klebsiella, it is the right upper lobe, and that too posterior segment of the right upper lobe, which is nothing but the bulging fissure sign. Okay, so this is about your Klebsiella pneumonia. Now you see a question here. X-ray finding of staphylococcal pneumonia are all except pneumatocele, hilar lymphadenopathy, empyema, visible air bronchograms. Okay, you take staphylococcal pneumonia, right, which is nothing but the Staphylococcus aureus. So Staphylococcus aureus is the one which will cause the bronchopneumonia. Right, which will cause the bronchopneumonia. Okay, now, so the consolidation what you will have in Staphylococcus aureus, it is the patchy consolidation. Right, the consolidation what you will observe here is the presence of the patchy consolidation. Like only limited areas, right, only limited areas are consolidated, and it is the, as the name itself suggests, that is bronchopneumonia. Bronchi are involved. Right, bronchi are involved, and chest X-ray, it shows the presence of patchy areas of consolidation. Right, patchy areas of consolidation. Okay, so that is what the chest X-ray shows. And what is the most common organism causing your bronchopneumonia? That will be your Staphylococcus aureus. right? That will be your Staphylococcus aureus. So this is about your bronchopneumonia. So the question is, X-ray finding of staphylococcal pneumonia are all except pneumatocele is present, empyema will be there as a part of your synpneumonic effusion, visible air bronchogram is present because there is presence of patchy consolidation, but hilar lymphadenopathy, it is not the feature of the Staphylococcus aureus. So this is your anatomical classification of pneumonia, right? Still we did not discuss about the interstitial pneumonias. I will discuss that in detail subsequently, but before going on to that, let me discuss the other classification of pneumonias. So the other classification, I said, it is like from where the organism has been acquired. So accordingly, the pneumonias are being classified in the following manner. That is, community acquired pneumonia, right? And the next important form of pneumonia will be nosocomial pneumonias, right? Will be nosocomial pneumonias. So these nosocomial pneumonias are again further classified as hospital acquired pneumonias, right? They are further classified as the hospital acquired pneumonias, and second one is ventilator-associated pneumonias, right? VAP stands for ventilator-associated pneumonias. This is the classification of your nosocomial pneumonias. Now, let me discuss in detail about the community acquired pneumonia. So, community acquired pneumonia, it is diagnosed outside of the hospital in the ambulatory patients who are not residents of nursing homes or other long-term care facilities. So the word itself tells you the individual has acquired the organism, right? The individual has acquired the organism outside the hospital. Okay, so that is what is the definition of the community acquired pneumonia, right? And these individuals who have developed the community acquired pneumonia, they are not the residents, right? They are not the residents of nursing home, right? They are not the residents of nursing home or long-term care facilities. So that is about your community acquired pneumonias. Now, if you see the question, most common bacterial pathogen identified in most studies of community acquired pneumonia is the Streptococcus pneumonia, right? And this Streptococcus pneumonia, it accounts for approximately 2/3 of the bacterial isolates, right? In almost 2/3 of bacterial isolates, you have this Streptococcus pneumonia. Now, what are the other common bacterial pathogens included? That includes Haemophilus influenza, number 2, Mycoplasma pneumonia, Chlamydia pneumonia, right? Number 4, Staphylococcus aureus, Moraxilla catarrhalis, right? Moraxilla catarrhalis, then Klebsiella pneumonia. So these are all the organisms which will cause the community acquired pneumonias. So if you see the viral organisms causing community acquired pneumonia, these include coronavirus, then influenza virus, then followed by that respiratory syncytial virus, adenovirus, and next parainfluenza virus. Right, parainfluenza virus. So these are the common viral infections which will cause the community acquired pneumonia. Then followed by that, you should know what are the risk factors for the development of community acquired pneumonia. So if you take the risk factors, that includes number 1, advanced age of the individual. So with advancing age, the immunity of the individual decreases. As the immunity of the individual decreases, the individual is more prone for infections. And another important risk factor is alcoholism, next tobacco use, and patients with history of asthma or COPD, then immunosuppression. Okay, so these are the risk factors for the development of the community acquired pneumonia. Now, after having discussed about community acquired pneumonia and what is the next form of pneumonia, the next form is nosocomial pneumonia. Nosocomial pneumonias are those pneumonias either they are acquired from hospital or they are acquired in an individual who is on ventilator. So if you see this hospital acquired pneumonias, they are the one which occurs, right, which occurs 48 hours or more after admission to the hospital. That is what is called as hospital acquired pneumonia. And the organisms causing this hospital acquired pneumonias, they include Pseudomonas species, then followed by that Escherichia coli, next Klebsiella species, and other important organisms are Staphylococcus aureus, Enterobacter, then lastly Acinetobacter species. Right, Acinetobacter species. So these are the organisms which will cause the hospital acquired pneumonias. Now there is a very important question related to your nosocomial pneumonias. Nosocomial pneumonias is the one most commonly caused by gram-negative bacilli, gram-positive bacilli, gram-negative cocci, Mycoplasma. So please remember, nosocomial pneumonias are the pneumonias caused by gram-negative bacilli. Right. So nosocomial pneumonias are common in immunocompromised patients. Right. This is very important. Right. They are very common in immunosuppressed or immunocompromised patients. Okay. And it is characterized by colonization of nasopharynx. Right. Colonization of nasopharynx with gram-negative bacilli. Okay, next. Followed by that, another form of nosocomial pneumonia is ventilator-associated pneumonias. So, ventilator-associated pneumonias, what is the definition? It is the development of pneumonia in an individual after endotracheal intubation for more than 48 to 72 hours. Okay, so it is the development of pneumonia in an individual who is on endotracheal tube for almost 48 to 72 hours. Right, for almost 48 to 72 hours. Now, what are the organisms which will be causing this ventilator-associated pneumonias? The organisms are, number 1, Acinetobacter species. Right, number 1, Acinetobacter species, and S. maltophilia. And apart from these organisms, we have anaerobic organisms that can cause these ventilator-associated pneumonias. Anaerobic organisms include like bacteroids and as well as the fusobacterium. Now, we have one more type of the nosocomial pneumonia. One is hospital-acquired pneumonia. Second one is ventilator-associated pneumonia. Then we have what is called as the clinical conditions associated with healthcare-associated pneumonia. Right? What do you mean by this word? Healthcare-associated pneumonia. Healthcare-associated pneumonias means what should be the criteria to call it as healthcare-associated pneumonia? Number 1, the individual should have been hospitalized for more than 48 hours. Right? The individual should have been hospitalized for more than 48 hours, and the individual should have been hospitalized for more than 2 days in the prior 3 months. Right? The individual should have been hospitalized for more than 2 days in prior 3 months. That is another criteria to call it as healthcare associated pneumonias. Right? Or the individual would have been admitted in the nursing home nursing home or extended care facility. Right, or extended care facility, or the patient on chronic hemodialysis, right, or the patient on chronic hemodialysis, or the patient on home infusion therapy. Okay, so this is what the criteria for to call it as the healthcare associated pneumonia. Any of these, the individual has developed pneumonia after getting hospitalized for more than 48 hours, or the individual has developed pneumonia with a history of hospitalization for 2 days in the prior 3 months, or the individual being present in the nursing home or extended care facility for a prolonged period of time, the individual on chronic hemodialysis or home infusion therapy. So any of these can lead to the development of the healthcare associated pneumonias. Now, after having discussed about the anatomical classification, so anatomical classification, we have discussed air-space pneumonia, that is Lobar pneumonia and bronchopneumonia. Right, interstitial pneumonia still we did not discuss. I will discuss that subsequently. And then the another form of pneumonias like what we have discussed is community acquired pneumonia and as well as the nosocomial pneumonias. Now, what I will do first, I will discuss the clinical features in detail overall pneumonias. So the clinical features, if you observe, pneumonia is what it is, basically an infection. So the individual will have a very high grade fever, and this particular high grade fever, it is associated with chills and as well as rigors. Then apart from the fever, the other important thing is the respiratory system manifestations, and this respiratory or pulmonary manifestations will be in the form of cough with expectoration. Right, so there will be development of cough with expectoration. So the majority of the lung is damaged either in the form of consolidation, that is the entire lobe is being consolidated in lobar consolidation or lobar pneumonia, or patchy consolidation in bronchopneumonia. So thereby what will happen, the amount of lung parenchyma which is required for air exchange is reduced. So that is the reason why the individual will have difficulty in breathing. And these patients with pneumonia, they can develop pleural effusion causing pleuritis, and due to which they will develop the pleuritic chest pain. And these individuals, they can have complications like development of hemoptysis. And once these patients with pneumonia, if they go into a state of severe sepsis, right, once they go into a state of severe sepsis, they develop vascular manifestations, that is hypotension, right? That we call it as the septic shock. Cardiac manifestations is that you take any form of infection, right? Whenever there is fever, there will be tachycardia, right? There will be high heart rate. Gastric manifestations in the form of nausea and as well as vomiting, right? And generalized manifestations, that is in the form of the joint pains and as well as the muscle fatigue. So these are the main symptoms of the pneumonia. Now, very important is about the sputum production. Depending upon the color of the sputum, we will be able to make out what is the underlying organism causing pneumonia. Like for suppose, if the color of the sputum, if it is green or yellow colored thick sputum, that indicates the bacterial infection. Right, that indicates the bacterial infection. Right, and if the individual has the black colored sputum, black colored sputum is suggestive of the co-workers pneumoconiosis. Right, co-workers pneumoconiosis. Okay, and the another important multiple choice question you should know is that the green color, right, the green color to the sputum is imparted by an enzyme, that is myeloperoxidase. Right, it is imparted by an enzyme, that is myeloperoxidase, which is also called veroperoxidase. Right, which is also called veroperoxidase. Okay, next, rusty sputum. The presence of rusty sputum is very much suggestive of pneumococcal pneumonia. Right, it is very much suggestive of pneumococcal pneumonia. So that is what is your rusty sputum suggestive of. And the presence of the red currant jelly. Red currant jelly sputum, it is seen in the Klebsiella pneumonia. Right, it is present in Klebsiella pneumonia. Then followed by that, pink frothy sputum. It is suggestive of the pulmonary edema. Right, in the sputum, if it is like a pink frothy color is present, that is suggestive of an underlying pulmonary edema. And if it is a blood stained sputum, that is suggestive of pulmonary tuberculosis. Anchovy sauce sputum, right, it is present in ruptured amoebic liver abscess. Right, it is present in ruptured amoebic liver abscess. So that will be your anchovy sauce sputum. Next, so depending upon the color of the sputum, we will be able to make out what is the underlying organism or what is the underlying condition causing cough with expectoration. Next important thing is based on the risk factor. Right, based on the risk factor also we can attribute what is the organism causing pneumonia within the individual. Like for example, if the individual is alcoholic, the chance of aspiration is very common. So once there is an aspiration, what will be the organism in the mouth? It is anaerobic organisms. So in alcoholics, it is the anaerobic organisms. Right, it is the anaerobic organisms which will be causing the pneumonia. And apart from that, in alcoholics, it is even Mycobacterium tuberculosis, right, and then followed by that Streptococcus pneumonia. So these are the organisms which will be causing pneumonia in alcoholics. You take in smokers, right, an individual with smoking, what are the organisms that are being attributed for the development of pneumonia? Number one, Streptococcus pneumonia. right? Number 2, Haemophilus influenzae. Then Moraxella catarrhalis. Right, Moraxella catarrhalis. Then lastly, Legionella pneumophila. So these are the organisms which will cause pneumonia in smokers, right? Now, if the individual has the risk of exposure to birds, then the organism that will cause pneumonia is Chlamydia psittaci. Right, the organisms that will cause pneumonia is Chlamydia psittaci, right, if the individual has risk of exposure to birds. So that we call it as the bird handler's pneumonia, right? And what is another name of this particular bird handler's pneumonia? Because it is being caused by Chlamydia psittaci, this is also called as psittacosis. Right, this is also called as psittacosis, and the causative agent is Chlamydia psittaci. And let me tell you, it is the one which will cause interstitial pneumonia. So interstitial pneumonia is the one where the individual has inflammation of the interstitium of the lung. And what will be the treatment for this bird handler's pneumonia? It is azithromycin. That will be the first line drug. Right, azithromycin will be the first line drug. Okay, and this azithromycin, it has to be continued for 10 to 14 days. Right, it has to be continued for 10 to 14 days, right? That too, azithromycin 500 milligrams. Now, so that is about like if the individual has risk of getting exposed to birds, the organism that will cause pneumonia is Chlamydia psittaci. For suppose, if the individual has risk of getting exposed to the farm animals, then the organism which will be causing pneumonia will be Coxiella burnetii. Right, Coxiella burnetii. And for suppose, if the individual has risk of aspiration of the stomach contents, then the organisms that will be causing pneumonia will be anaerobes. Right, and in patients with cystic fibrosis, the organisms which will be causing pneumonia will be Pseudomonas aeruginosa. Right, Pseudomonas aeruginosa and Staphylococcus aureus. And if you take Streptococcus pneumonia, this is more common in winter season. Okay, so depending upon the underlying risk factor to the individual, we can make out what is the organism that will be causing pneumonias. So we have discussed the clinical features in patients with the pneumonias. Then what will be the examination findings in patients with the pneumonias? That is, which of the following is the correct statement about pneumonia? Bronchophony, decreased vocal fremitus, shifting of the trachea, amphoric breathing. The answer to this question is the presence of the bronchophony is the feature of your pneumonia. Now let me tell you what will be the examination findings in patients with pneumonia. On inspection and palpation, right, on inspection and palpation, in patients with the consolidation, what will happen? The chest wall movements, right, the chest wall movements will be reduced. Right, the chest wall movements are reduced at the site of consolidation. That is one point. Second, what will happen to the vocal right? So what will happen to the vocal fremitus? The vocal fremitus, it is increased. And how do you elicit this particular vocal phlebitis? Right, you need to keep the ulnar aspect of the hand over the area of consolidation and you should ask the individual to speak. Then the vibrations which are generated within the lung parenchyma are transmitted onto the surface of the chest wall and that is being felt by the ulnar aspect of the hand which you have kept over the chest wall. And over the area of consolidation, there is increased transmission or increased vibrations which are being felt over the area of consolidation. And that is what is nothing but your vocal phlebitis is increased. Okay, right. Then on percussion, you will have the presence of woody dull note. Right, you will have the presence of woody dull note. Okay, so this we call it as tactile vocal phlebitis. Right, why am I using the word tactile? Because you're touching the surface of the chest with the ulnar aspect of the hand. That will be your tactile vocal phlebitis. Okay, next on auscultation, right, on auscultation, okay, you have the bronchial breath sounds. Okay, and what type of bronchial breath sounds are being heard? Tubular type of bronchial breath sounds are being heard. And what is the difference of these bronchial breath sounds from normal vesicular breath sounds? Bronchial breath sounds are those which are high pitched sounds. Right, which are the high pitched sounds. Okay, which one? The bronchial breath sounds. Then you also have additional sounds apart from the bronchial breath sounds in patients with the consolidation, and that will be bronchophony. So bronchophony is heard in patients with consolidation. And what is this? It is a phenomenon of patient's voice remaining loud at the periphery of the lung. So over the area of consolidation, you keep the stethoscope and you ask the individual to speak. Over the area of consolidation where you have kept the stethoscope, the patient's voice is heard louder than normal. That is what is called as bronchophony, which is present in patients with the pneumonia. Next, another important additional sound or added sound that the individual will have is egophony. So, what do you understand by this word egophony? Egophony is an auscultation of the sound A, right? Auscultation of the sound A instead of E. Right? Auscultation of the sound A instead of E when the patient phonates E. Actually, what happens here is you keep the stethoscope over the area of consolidation, right? And you ask the patient to tell the word E. But you will listen that as the A. That is what is called as the egophony, right? You have a change. See, this particular change in note is due to abnormal sound transmission through consolidated lung. Okay, so this change is due to abnormal sound transmission, right? Abnormal sound transmission through consolidated lung. That is what is called as the egophony. Okay, now after having discussed about the examination findings in patients with your lobar pneumonia, let me discuss in detail about the interstitial pneumonia. So the name itself tells you, interstitial pneumonia is that where the inflammation, right, the inflammation is confined only to the interstitium of the lung. Right, it is confined only to the interstitium of the lung. And this interstitial pneumonia, this is also called as the atypical pneumonia. And why is that it is called as atypical pneumonia? Because the typical features of airspace pneumonia, they are absent. Right? The typical features of the airspace pneumonia are absent. And you have the atypical features. What are those atypical features of pneumonia? Number one, right? Very minimal amount of sputum. Or it is absent sputum in patients with the atypical pneumonias. And there are no signs of consolidation. Just now we have discussed the signs of consolidation. What are those? Like increase in the tactile vocal fremitus, presence of woody dull note, bronchial breathing, egophony, bronchophony. These are the signs of consolidation, but that will be absent in atypical pneumonias. And there is only moderate elevation of WBC. Right, there is only moderate elevation of the WBC, and there is also lack of alveolar exudate. Right, there is also lack of alveolar exudate. So these are the features of the atypical pneumonias. Now, these organisms causing the atypical pneumonias, they are predominantly obligate intracellular pathogens. Right, they are obligate intracellular pathogens, and the infection, right, it is restricted to interstitium of the lung. Right, it is restricted to interstitium of the lung, and there is no outpouring of the fluid. Right, there is no outpouring of the fluid from alveolar septa to the alveoli. Right, there is no outpouring of the fluid from alveolar septa into the alveoli. So in the sense, there is absence of alveolar exudate. Right, there is absence of alveolar exudate. So there is no alveolar exudate in these patients with the atypical pneumonia. Right, and if you take the inflammatory infiltrate, it is mainly lymphocytic predominant. Right, it is mainly lymphocytic predominant. So these are some of the features of the atypical pneumonia. Few more features if you see. Right, few more features if you see. Usually the atypical causes also involve the atypical symptoms, like these atypical pneumonias, they do not respond to common antibiotics. Right, no response to common antibiotics. Right, that is one point. Second thing is, there are no signs and symptoms of lobar consolidation that I have taught you already. And in these individuals, there is also presence of extrapulmonary symptoms. Right, there is also presence of the extrapulmonary symptoms. Right, and that is related to the causative organism. So if you see this question, All of the following features are seen in viral pneumonias except presence of interstitial inflammation, predominance of alveolar exudate, bronchiolitis, multinucleate giant cells in the bronchiolar wall. So, you take these viral pneumonias, most of the time they are atypical pneumonias, right, which is nothing but interstitial pneumonias. So, if it is the interstitial pneumonias, you don't have the alveolar exudate, right? You don't have the alveolar exudate, right? In viral pneumonias, you have interstitial inflammation, you have the presence of bronchiolitis, multinucleate giant cells in the bronchiolar wall can be seen. So now, if you see this question of differences between lobar pneumonia and as well as the atypical pneumonias. In lobar pneumonia, the organism is an extracellular organism, whereas atypical pneumonia, it is an obligate intracellular organism, right? It is an obligate intracellular organism. And in lobar pneumonia, you have the features of consolidation, right? You have the features of consolidation, whereas in atypical pneumonias, right, there is no features suggestive of consolidation, right? There are no features suggestive of consolidation, and the inflammation is restricted or confined only to interstitium. And if you see the infiltrate in lobar pneumonias, infiltrate in case of lobar pneumonias, it is neutrophilic predominance, whereas infiltrate in case of atypical pneumonias, it is lymphocytic predominance. And in lobar pneumonia, you have the features of typical pneumonia, like the individual has fever, high grade fever with chills and rigors, productive cough, and there is also presence of hemoptysis. Whereas in atypical pneumonia, these individuals, they don't have cough with expectoration, they have dry cough, right, and they have very few localizing signs in atypical pneumonias. And the chest x-ray in patients with the lobar pneumonia, it will show you the large areas of consolidation, right, and which show you the presence of air bronchograms. Right, which show you the presence of the air bronchograms. Whereas in atypical pneumonia, the chest x-ray, it will show you interstitial pattern. Right, chest x-ray, it will show you the interstitial pattern. So that is about the features suggestive of atypical pneumonia. So these are some of the differences between lobar and as well as the atypical pneumonias. And even if you observe the chest x-ray in patients with the interstitial pneumonia, the pattern, what we call it as interstitial pattern, right? This pattern, we call it as the interstitial pattern. So if you see this question now, all of the following are seen in viral pneumonias except predominance of alveolar exudate is not seen in viral pneumonias. And if you see the organisms causing the atypical pneumonias, if you see the question here, atypical pneumonia is caused by all except Mycoplasma pneumonia, Legionella pneumophilia, human coronavirus, Klebsiella pneumonia. Let me tell you, we have discussed that Klebsiella pneumonia is the one which will cause lobar pneumonia, right? And the name given to that is the Friedlander's pneumonia. And which lobe is affected? It is the upper lobe. posterior segment of upper lobe, and that we call it as bulging fissure sign. Now, if you see the organisms causing the atypical pneumonias, please remember the mnemonic, that is MLC. Okay, M stands for Mycoplasma, L will be Legionella, C will be Chlamydia, right? Mycoplasma, Legionella, Chlamydia, right? These are the important organisms causing the atypical pneumonias. And apart from that, if you take the viral causes for atypical pneumonias, they include respiratory syncytial virus, then influenza A and B, next parainfluenza, adenovirus, then severe acute respiratory syndrome, that is SARS virus, then measles virus. So these are the viral causes for pneumonias. Which one? The atypical pneumonias. Okay, so the question, if you see, the answer is Klebsiella pneumonia. Now you see one more question. 28-year female has diarrhea, confusion, high grade fever with bilateral pneumonitis. Diagnosis is Legionella, Neisseria meningitidis, Streptococcus pneumonia, Haemophilus influenza. So let me tell you, the organism here is Legionella, right? The organism here is the Legionella pneumonia. Now if you talk about this Legionella pneumonia, it is a gram-negative organism, right? And it is a motile organism which is non-encapsulated bacilli. Right, which is a non-encapsulated bacilli. Okay. Next, man-to-man transmission does not occur. Right, man-to-man transmission does not occur in case of Legionella. Infection is typically acquired by inhalation of the aerosols. Right, inhalation of the aerosols. Okay, and you have to know that there is no animal reservoir. Then what are the reservoirs for Legionella? It is the air conditioners which are considered as the reservoirs for Legionella. So there is no animal reservoir, right? There is no animal reservoir. So these patients, they present with dry cough, right? They present with dry cough. Okay, and they also have extrapulmonary manifestations, and these extrapulmonary manifestations, they include diarrhea, confusion. The CNS manifestation will be there, that will be in the form of confusion. Then anorexia and headache. These are the extrapulmonary manifestations that you will have in Legionella pneumonia. And at the same time, you should also know what are the common risk factors for the development of the Legionnaire's disease. The risk factors include, number 1, advancing age of the disease, or advancing age of the individual, immunocompromised patients. And who are those group of individuals who are immunocompromised? They include transplant patients, right? Number 2, patients with HIV. Number 3, glucocorticoid recipients. Next, patients with hairy cell leukemias. Okay, so these are like these are the group of individuals who are at risk of development of Legionella pneumonia. Next, smokers, diabetic patients, and patients with chronic lung disease. So these are the group of individuals who are at risk of development of the Legionella disease. Now, when is that you have to think of Legionella disease? If the following features are there. For example, if the individual is having the risk factors like immunocompromised or smoker, or the individual is at risk of chronic lung disease. Next, individual is having high fever, gastrointestinal difficulties like diarrhea, neurological abnormalities like confusion, right? Numerous neutrophils but no organism revealed by gram staining. Hyponatremia is being present and failure to respond to your beta-lactam group of antibiotics. That is when you have to consider the Legionella pneumonia. So you have to remember this. These patients with Legionella, they have an important electrolyte abnormality, that is hyponatremia, and that could be because of the diarrhea as well. Okay, so the answer here, female have diarrhea, confusion, high grade fever with bilateral pneumonitis. The answer is Legionella pneumophilia. Next, which of the following is not true about Legionella pneumonia? Seen mainly in immunocompromised patients. Erythromycin is the drug of choice, common in patients with hairy cell leukemia. Smoking and alcohol are the risk factors. The answer here is erythromycin is the drug of choice is an incorrect statement. Then what is the drug of choice? In Legionella, it is azithromycin which is considered as the drug of choice. Right? Azithromycin which is considered as the drug of choice, the first choice. And second choice will be erythromycin. And third choice will be trimethoprim plus sulfamethoxazole or doxycycline. Okay, so this is about which of the following is not true about Legionella. Right, next. Drug of choice for Mycoplasma pneumonia. See, Mycoplasma is another important organism which will cause atypical pneumonia or interstitial pneumonias. Now, let me tell you about Mycoplasma pneumonia. That is, it is the smallest free living organism. Right, it is the smallest free living organism, and it is seen in young patients of age group 5 to 15 years. And this Mycoplasma will cause atypical pneumonia. And next, there will be lower lobe involvement. Right, there will be lower lobe involvement. And complications that can be seen with Mycoplasma pneumonia is that the individual will develop autoimmune hemolytic anemia. Right, autoimmune hemolytic anemia. And there can be development of erythema multiforme, Next, Stevens-Johnson syndrome. Okay, so these are the complications that can be encountered in patients with the Mycoplasma pneumonia. And what is the drug of choice in patients with the Mycoplasma pneumonia? Drug of choice will be macrolide, that is erythromycin. Right, so erythromycin, this is considered as the drug of choice. Okay, now for Mycoplasma pneumonia, the drugs that can be given is azithromycin, erythromycin, then clarithromycin. Okay, so these are the antibiotics for Mycoplasma pneumonia. And for Ureaplasma ureolyticum and Ureaplasma parvum, the drugs what we give is azithromycin and clarithromycin. Right, azithromycin and then clarithromycin. Okay, so these are the antibiotics for Ureaplasma ureolyticum and Ureaplasma parvum. Now, after having discussed about Legionella, Mycoplasma, you see another important question. All of the following statements about Pneumocystis jirovecii are true except usually associated with cytomegalovirus infection, may be associated with pneumatocele, usually diagnosed by sputum examination, causes disease only in the immunocompromised patients. So, if you take this PCP, right, which is also called Pneumocystis jirovecii pneumonia, let me discuss and then come back to the question. See, PCP pneumonia, it occurs in immunocompromised host. Right, it occurs in the immunocompromised hosts. Right, like patients with AIDS and transplant recipients. Right, transplant recipients. And this PCP or Pneumocystis jirovecii pneumonia, the type of pneumonia that you will have is interstitial pneumonia. Third, it presents as dry cough. The individual also has fever and exertional breathlessness will be there. This is the very important point related to PCP pneumonia. And when you examine the respiratory rate in these individuals, they'll have tachypnea. Right? The respiratory rate is increased. And how will you diagnose this Pneumocystis jirovecii pneumonia? Either by sputum examination or by chest X-ray. So, if you take the sputum examination, so the sputum has to be induced because the individual is having dry cough. So, sputum examination is done by inducing the sputum production, right? And to that particular sputum, you have to apply methenamine silver stain. Right, you have to apply methenamine silver stain. Okay, and the chest X-ray. See, in early stages, the chest X-ray may be normal, but as the severity of the disease progresses, right, as the severity of the disease progresses, the individual develops ground glass appearance. right? The individual develops the ground glass appearance. Okay, right. That will be the chest X-ray. Now, followed by that, if you see the definitive diagnosis, see sputum examination, I said you, the sputum production is done by induction, or the sputum production is done by inhalation of the hypertonic saline. And this sputum has to undergo methenamine silver staining. And another way of definitive diagnosis is the fiber optic bronchoscopy with bronchoalveolar lavage. So this will be the mainstay of diagnosis, right? This will be the mainstay of diagnosis. And this fiber optic bronchoscopy with bronchoalveolar lavage, this will provide information about the organism burden, right? It will tell you what is the quantity of the organism, right? It will tell you about the organism burden, right? And it will also tell you about host inflammatory response, right? It also tells you about the host inflammatory response. So that is about the fiber optic bronchoscopy with bronchoalveolar lavage. Then you take this transbronchial biopsy and open lung biopsy. This transbronchial biopsy and open lung biopsy, this is the most invasive procedure. Right, this is the most invasive procedure and used only when the diagnosis cannot be made by bronchoalveolar lavage. Right, if bronchoalveolar lavage is unable to demonstrate the pneumocystis jirovecii pneumonia, that is the point when you need to do this transbronchial biopsy and open lung biopsy. Now, finally, if you see the treatment in these individuals, definitely the antibiotics, that will be the mainstay of treatment. Okay. And these antibiotics, that has to be given for nearly around 1 to 2 weeks. Right, that has to be given for nearly around 1 to 2 weeks. And then treatment of complications. Ventilatory support is very, very important. Right, as and when required, ventilatory support, right, that is very much required. And you should know what will be the antibiotic of choice. So you see this question. All of the following are used in the treatment of PCP except pentamidine, dapsone, cotrimoxazole, fluoroquinolone. Now, if you see, the drug of choice will be your cotrimoxazole. Right. Now, what is this cotrimoxazole? Cotrimoxazole, it is a combination of trimethoprim, sulfamethoxazole. So, this trimethoprim, sulfamethoxazole, which is available as Bactrim, is the drug of choice or the first line drug for PCP pneumonia. The other agents that can be given for PCP, it includes trimethoprim plus dapsone. Number 2, etovaquone. Number 3, clindamycin. Plus primaquine. Or pentamidine. And other alternative that can be given is trimethoxate plus leucovorin. Right, trimethoxate plus leucovorin. These are the other alternative agents that can be given for your PCP pneumonia. The adjunctive agent is prednisolone. Right, the adjunctive agent is the prednisolone. So this will be the antibiotics that can be given for PCP pneumonia, but the first line is trimethoprim sulfamethoxazole. So going to the question, all of the following are used in the treatment of PCP except pentamidine can be given, dapsone, it is an anti-leprotic agent, can also be given in the treatment of PCP. Cotrimoxazole can be given, but fluoroquinolones, they are not given in the treatment of the PCP pneumonias. So if you see the next question, round pneumonia is seen with streptococcal pneumonia, kerosene oil aspiration, lung cancer, Mendelssohn syndrome. The answer to this question is the streptococcal pneumonia, right? You can see here the consolidation, right? It is round in appearance. So streptococcal pneumonia infection is characterized by homogeneous parenchymal lobar opacities with the presence of air bronchograms. And this round pneumonia, if you see, this condition can occasionally manifest as round opacity simulating a pulmonary mass. Okay, so this actually it simulates it simulates the pulmonary mass. Okay, which one? This particular round pneumonia, right, which is a round opacity, it simulates the pulmonary mass. Now this round pneumonia, it is seen mainly in the children, right? This round pneumonia, it is mainly seen within the children, right? Now why does it occur in children? Let me also explain you. See, the proposed theory about why children develop round pneumonia and adults do not develop the round pneumonia is due to development of interalveolar communication. You see here, this is the interalveolar communication. This interalveolar communication, that is pores of Kohn, is seen in children. Right, it is seen in children. And the collateral airway communication, and this collateral airway communication, that is canal of Lambert, that is also seen in children. Right, that is also seen in children. So this is the proposed theory, right? The proposed theory about why children develop round pneumonia is that due to development of the interalveolar communication, that is pores of Kohn, and collateral airway communication, that is canal of Lambert. These communications, they are seen only in children, and this will give you the presence of a round opacity, because the spread of the inflammatory infiltrate will be surrounding, and that will give you a round opacity, which is nothing but the round pneumonia. Whereas in adults, right, you don't have the adjacent spread. In adults, there will be lateral dissemination of infection. Right, there will be lateral dissemination of infection. So because of lateral dissemination of infection throughout the lobe, right, the lateral dissemination of infection is throughout the lobe, and that will lead to what is called as lobar pneumonia. Right, that will lead to what is called lobar pneumonia. Okay, in children you have the round pneumonia, whereas in adults you have the lobar pneumonia. Okay, after having discussed about the round pneumonia, and round pneumonia, you should know the etiology, that is your Streptococcus pneumonia. Now see, one classification is anatomical classification, that is airspace pneumonia, right, which includes the lobar pneumonia and bronchopneumonia, and then interstitial pneumonia. And another important classification is the community acquired pneumonia, and then the nosocomial pneumonias. Nosocomial pneumonias, again we have hospital acquired pneumonias and ventilator associated pneumonias. Okay, then we have another important classification, that is classification by etiology, that includes the primary pneumonias, secondary pneumonias, and as well as the suppurative pneumonias. So if you take the primary pneumonias, so primary pneumonia is caused by a specific pathogenic organism. Right, it is caused by a specific pathogenic organism, and in primary pneumonias there is no pre-existing abnormality. Right, there is no pre-existing abnormality of the respiratory system. That is what you will see in the primary pneumonias. And what are the organisms which will cause the primary pneumonia? The most common organism will be Streptococcus pneumonia. Right, Streptococcus pneumonia. And other organisms are the Haemophilus influenza, next Moraxella catarrhalis, then Staphylococcus aureus, Legionella pneumophilia, then Mycoplasma pneumonia. So these are the organisms which will cause the primary pneumonias. And if you see the less common organisms, that includes Klebsiella, Streptococcus pyogenes, Pseudomonas aeruginosa, Coxiella burnetii, Chlamydia and Chlamydia psittaci, and viral infections like H1N1 influenza virus, seasonal influenza virus, coronavirus, and then Actinomyces israelii. So these are the less common organisms causing the primary pneumonias. Then if you take the secondary pneumonias, secondary pneumonia also called as the aspiration pneumonia. So this secondary pneumonias, it is characterized by the absence of any specific pathogenic organism in the sputum and the presence of some pre-existing abnormality of the respiratory system. Okay, so in primary pneumonias, there is no pre-existing abnormality of the respiratory system, but here there is presence of, right, there is presence of pre-existing abnormality. Right, there is presence of pre-existing abnormality of the respiratory system. And the pre-existing abnormality of the respiratory system, this will predispose to the invasion of lung by the organism. Right, this will predispose invasion of the lung by the organisms. Okay, and this predisposition of invasion of the lung by organisms is the one which is responsible for the development of your secondary pneumonias. Right, now what are the risk factors for the aspiration pneumonias? Let me tell you, small amount of material from the buccal cavity, particularly during sleep, it can enter into the respiratory tree. Right, in a healthy individual, the aspirated material will not cause pneumonia. Small amount of material from the buccal cavity may enter into the respiratory tree. But why do you think that in a healthy individual that small amount of material from the buccal cavity does not cause pneumonia? That is because in a healthy individual, you have the presence of mucociliary action and alveolar macrophages. So because of the presence of mucociliary action and alveolar macrophages, there is no disease in healthy persons. Right, there is no disease in healthy persons even though small amount of material is being aspirated. But what are the Causes of aspiration pneumonia. Number one, the aspiration of aspiration of pus from infected nasal sinuses. Number two, aspiration of gastric contents aspiration of gastric contents in patients with the GERD, that is gastroesophageal reflux disease. Then in acute bronchitis, bronchiectasis, in acute bronchitis, bronchiectasis and lung abscess. In acute bronchitis, bronchiectasis and lung abscesses, pus may be carried into the alveoli. Pus may be carried into the alveoli. And fourth, ineffective coughing. Ineffective coughing and laryngeal paralysis. Ineffective coughing and laryngeal paralysis. This will predispose to the aspiration. Okay, these are the causes of the aspiration and development of aspiration pneumonia. And next important thing is, how does the gastric contents cause the aspiration? So you have to know that the acidity of the gastric contents, you have to know that the acidity of the gastric contents, they result in the chemical burns. They result in chemical burns to the tracheobronchial tree. They result in chemical burns to the tracheobronchial tree. And this chemical burns to the tracheobronchial tree is the one which is involved in aspiration. And when will this chemical burn of the tracheobronchial tree occurs? That will occur if the pH of the aspirated content, if it is less than 2.5, and if the volume of the aspirated content, if it is greater than 0.3 ml per kg, if the volume of the aspirated content, if it is more than 0.3 ml per kg of the body weight, then it has a greater potential for causing the chemical pneumonia. It has greater potential in causing the chemical pneumonia. So 0.3 ml per kg. So that is roughly around, for suppose, 20 to 25 ml in adults. 20 to 25 ml in adults. This has greater potentials for causing the chemical pneumonia. So chemical pneumonitis is mainly because of the aspiration of the gastric contents having the pH of less than 2.5, of volume around 0.3 ml per kg of the body weight. Then, what are the signs and symptoms of aspiration pneumonitis? Commonest sign of aspiration pneumonitis is cyanosis, tachypnea, crepitations, rhonchi. let me tell you, the commonest sign of aspiration pneumonitis is tachypnea. Next question. Which is not correct about aspiration pneumonia? 5 to 15% of the community acquired pneumonia is due to aspiration pneumonia. Anaerobic infection is most common. Superior segment of the apex of the lung is commonly involved in recumbent position. 20 to 25 ml of the fluid less than pH 2.5 is required for aspiration pneumonia. Now let me tell you. The first statement is true statement. 5 to 15% of community acquired pneumonia is due to aspiration pneumonia is a true statement. Anaerobic infection is most common in aspiration pneumonia is also a true statement. And 20 to 25 ml of fluid less than pH of 2.5 is required for aspiration pneumonia is also a true statement. But the third statement, it is not correct. Superior segment of the apex of the lung is commonly involved in recumbent position is the wrong statement. So let me tell you, for suppose, if the aspiration has occurred in supine position, which part of the lung is affected? It is mainly the superior segment of the superior segment of the right lower lobe is affected. Okay, you see, this is the lower lobe, right? This is the lower lobe, right? Superior segment of the right lower lobe is affected when the aspiration occurs in supine position. For suppose, if the aspiration occurs in standing or sitting position, then posterobasal segment of the right lower lobe is affected. Right, posterobasal segment of right lower lobe is affected. Okay, so if you take the lower lobe, right, this is the lower lobe, and posterobasal segment, you see here, this is the posterobasal segment of the right lower lobe is affected if the aspiration occurs in standing or sitting position. Now, if the aspiration occurs, right, if the aspiration occurs in lying on the right side, then the aspiration is on to the right middle lobe. Okay, right middle lobe is affected, that is the posterior segment. Right middle lobe is affected, and as well as the posterior segment of the right upper lobe. Okay, so you see here, this is the upper lobe and this is the posterior segment of the right upper lobe. These are the lobes which are affected if the aspiration occurs when the individual is lying on the right side. And when aspiration occurs in recumbent position, in such case, posterior segment of the upper lobes, right, posterior segment of the upper lobes and superior segment of the lower lobes, they are affected if the aspiration occurs in recumbent position. So if you observe that here, the posterior segment of the upper lobe, this is the posterior segment of the upper lobe, superior segment of the lower lobe, right, this is the superior segment of the lower lobe. These are affected when the aspiration occurs in the recumbent position. So going back to the question now, which is not correct about aspiration pneumonia? Superior segment of the apex of the lung is commonly involved in recumbent position is a wrong statement. So in recumbent position, it is the posterior segment of the upper lobe and superior segment of the lower lobe are most commonly involved lung sites, right? Then followed by that, another form of pneumonia. So we have discussed primary pneumonias, right, where there is no underlying lung pathology. Secondary pneumonias, right, where example is aspiration pneumonia, where there can be an underlying lung pathology as well. And third one is suppurative pneumonias, which is also called necrotizing pneumonias. Now, when will this suppurative or necrotizing pneumonias occurs? Like now you see here, in most of the pneumonias, whenever there is successful inactivation of the organism, complete resolution occurs and normal lung structure is restored, right? So, in most of the pneumonias, if there is successful inactivation of the organism, in such case, normal lung structure is restored, right? Normal lung structure is restored. But in some cases, complete healing does not occur. Right? Complete healing does not occur in some cases. In such cases where there is no complete healing, in these cases, there will be destruction of the lung tissue by inflammation. Right? There will be destruction of lung tissue . Right? There will be destruction of the lung tissue by inflammation. And there can be destruction of the lung tissue by the abscess formation. Right? And there can be destruction of the lung tissue by the development of fibrosis. And there can be destruction of the lung tissue by the development of bronchiectasis. So, the term suppurative pneumonia has been applied to this group of conditions, right? So, in those conditions where there is no complete healing and there is subsequent development of destruction of the lung by inflammation, abscess formation, fibrosis and bronchiectasis, that we call it as necrotizing pneumonia. And if you take the organisms which are responsible for the necrotizing pneumonia, that includes Staphylococcus aureus, then Klebsiella pneumonia is responsible for necrotizing pneumonia, and Streptococcus pneumonia is responsible for necrotizing pneumonia, and then Haemophilus influenza is the organism which will cause the necrotizing pneumonia. Okay, so this is about your necrotizing pneumonia or suppurative pneumonias. Now, so this is the classification now. We have discussed three classifications. One is anatomical classification, right, which is nothing but airspace pneumonia and interstitial pneumonia. Airspace pneumonia, it includes the Lobar pneumonia and bronchopneumonia. Second one is from where the organism has been acquired to the individual. That is community acquired pneumonia and nosocomial pneumonias. Nosocomial pneumonias, again we classify that into hospital acquired pneumonia and ventilator-associated pneumonia. And third one is based on the etiology, that is primary pneumonias, secondary pneumonias, and then necrotizing or suppurative pneumonias. Now, if you see the evolution of the consolidated lung, right, what are the stages of consolidation? We have the stage of engorgement, that is engorgement stage. So, in engorgement stage, newly involved regions they undergo engorgement of, or there will be engorgement of the alveolar capillaries. Right, there will be engorgement of alveolar capillaries. And this engorgement of the alveolar capillaries will be with frothy, serous, blood-tinged fluid. Right? Will be with frothy, serous, blood-tinged fluids. Okay? That will be your stage of engorgement. And from the stage of engorgement, the next important stage is the stage of red hepatization. So here, in the stage of red hepatization, the lung will be dry, granular, and there will be dark red lung surface, dark red, lung surface. Why the individual has dark red lung surface? Due to alveoli filled with the copious inflammatory exudate. So here the alveoli, they are filled with copious inflammatory exudate. Okay, that is what is your red hepatization. So let me just show you. So this is your red hepatization, right? So how is that lung appearing? It's a dry, granular, dark red lung surface. Why is that? Due to alveoli filled with copious inflammatory exudate. That will be your red hepatization. Then you see the gray hepatization. See, gray hepatization is due to the leukocytes, they pack into the alveoli, right? The leukocytes, they pack into the alveoli, and leukocytes, they pack into the alveoli. RBCs, they are lysed, and epithelial cells, right? Epithelial cells, they undergo degeneration. That will lead to gray hepatization. Okay, and the last stage is the stage of resolution. In the presence of antibodies, right? In the presence of antibodies, the pneumococci, that is the organism, right? The pneumococci is opsonized, and it is opsonized by the WBC, right? It is opsonized by WBC and it begins to get cleared. Then you will have the stage of resolution. So these are 4 stages. Number 1, stage of engorgement, right? Where there is engorgement of the alveolar capillaries with frothy, serous, blood-tinged fluid. And the next one is red hepatization, right? Where you have dry, granular, dark red lung surface. Why? Because the alveoli are filled with copious inflammatory exudate. And gray hepatization is that leukocytes, they pack into the alveoli, RBCs are lysed, epithelial cells, they degenerate, leading to gray hepatization. Resolution is, in the presence of antibody, the pneumococci are opsonized by the WBC and they begin to get cleared. That will be your resolution. And this is the image of the gray hepatization. Okay. Now, after having discussed about the stages of consolidation, how will you diagnose these pneumonias? Right, very simple, complete blood picture, it will show you polymorphonuclear leukocytosis. Right, there will be increase in your WBC count, right? Mainly in case of lobar pneumonias, it is neutrophilic predominance, and atypical pneumonias, it is lymphocytic predominance. And another way is by sputum examination. You need to do gram stain and then culture and sensitivity, right? And then culture and sensitivity. Okay, blood culture and sensitivity is another important investigation. Then finally, pneumococcal urine antigen test. So this pneumococcal urine antigen test, see, in patients where there is no sputum production, a positive urinary antigen test for Streptococcus pneumonia confirms the diagnosis of pneumococcal pneumonia. Right? Confirms the diagnosis of pneumococcal pneumonia. Okay? Where will you do this urine antigen test? In patients where there is no sputum production. Then coming to the complications of pneumonia. Right? The mnemonic is pneumo, is a mnemonic. P stands for pleural effusion. Right? The word N will be your necrotizing pneumonia. The word E will be empyema or lung abscess. Right? And the word U is uncommon complications. And these uncommon complications will be in the form of septic arthritis, endocarditis, and then osteomyelitis, right, and then meningitis. Right, so these are the uncommon complications of pneumonia. And then the word M. M stands for mechanical ventilator requiring complications. And what is that mechanical ventilator requiring complications? The individual can develop ARDS. Pneumonia is the most common cause for direct lung injury causing ARDS. And O stands for other serious complications like sepsis. Right? So these are the complications of the pneumonia. Now, let me discuss how will you assess the severity of the pneumonia. Right? We have a criteria or we have a scoring system called as Curve 65. Curve 65 criteria includes all except age more than or equal to 65 years, respiratory rate more than 30 per minute, systolic blood pressure more than 90, blood urea nitrogen more than 7 millimoles per liter. See, in the Curve 65, you should know that what is this CURB? The word C stands for confusion. U stands for blood urea nitrogen, that should be more than 7 millimoles or more than 19 milligrams per deciliter. The word R will be respiratory rate, right? That should be more than 30 per minute. And the word B, that is blood pressure, that should be less than 90 by 60 millimeters of mercury. And 65 stands for age of the individual more than 65 years. So, now you see here, if the individual has the following features, if the individual is confused, give a score of 1 point. Urea more than 7 millimoles per liter, give a score of 1 point. Respiratory rate more than 30, give a score of 1 point. Blood pressure less than 90, give a score of 1 point. Age or more than or equal to 65 years, give a score of 1 point. Now, which of the following is not included in your Curve 65 now? Systolic blood pressure, which is taken in the criteria, is less than 90 millimeters of mercury, right? Not more than 90 millimeters of mercury. So, the answer is C here. Now, what is the purpose of giving this particular scoring? That is, for suppose, if the score of the individual is in between 0 to 1, then 30-day mortality, right? 30-day mortality rate is around 1.5%. And how will you treat these patients? These patients have to be given antibiotics on outpatient basis. Oral antibiotics can be given. And if the score is 2, the 30-day mortality is around 9.2%. Right? And here the treatment has to be given by admitting the patient to the hospital. Right, the patient is admitted to the hospital and then IV antibiotics should be given. And if the score is 3, right, if the score is 3, then the 30-day mortality is around 22%. and the treatment in these patients should be done by admitting in ICU, and intravenous antibiotics should be given. So this is the importance of giving the scoring system. Now, apart from curve 65, we have another important scoring system for assessing the severity, that is, in pneumonia severity index in adults, most important factor is age, congestive heart failure, hyponatremia, hypothermia. The answer to this question is the age of the individual. Now let me tell you what are all the various parameters which we take in assessing which we take in pneumonia severity index. These are all the parameters, right? One is the age of the individual. Next, is there any presence of the coexisting illness, that is neoplastic disease, liver disease, congestive heart failure, or if there is any presence of renal disease. And you have to look for the findings on physical examination, that is altered mental status, respiratory rate more than 30, systolic blood pressure less than 90, temperature either hypothermia or hyperthermia, tachycardia if it is present or not. And laboratory and radiographic findings, right? ABG pH less than 7.5, sodium less than 130, glucose more than or equal to 250 milligrams per deciliter, hematocrit less than 30%, partial pressure of oxygen less than 60 millimeters of mercury, and presence of pleural effusion. See, these are all the various parameters that we take in the pneumonia severity index, but the most important factor is age of the individual. Now, after assessing the severity, now we will be able to know whether the individual is having uncomplicated pneumonia, whether the individual is having a moderately sick requiring hospitalization, and third is like the severely sick patient, and fourth is like the individual is having a underlying comorbidity also. Accordingly, you need to give the antibiotics as well. Like for example, you see here in uncomplicated pneumonias, right, where the patient is not requiring hospitalization, in such case the drug that can be given is azithromycin, or you can give amoxicillin, right? Right, no more erythromycin is being used as a first line, you can use the azithromycin, right, or amoxicillin can be used, or cefuroxime can be used. For suppose you need to consider the fluoroquinolones. Why I was using for suppose? For suppose if you are suspecting the atypical organisms or anaerobic organisms, then in such case the fluoroquinolones can be given. And another alternative agents are doxycycline, cefixime, cefpodoxime, cefprozil. So these are the antibiotics that can be given in uncomplicated pneumonia, and all these are oral route of administration. But in moderately sick patients requiring hospitalization, they have to be given intravenous antibiotics, and that includes ceftriaxone 2 gram once a day intravenously, or cefotaxime 1 to 2 gram 8th hourly, or azithromycin can be given. And the other drug that can be given is amoxicillin clavulanic acid plus azithromycin, or fluoroquinolones alone can be given in a moderately sick patient. Whereas in severely sick patients, then in such case you need to combine ceftriaxone 2 grams once a day plus azithromycin, or levofloxacin has to be combined. For suppose if the individual is allergic to your beta-lactam group of antibiotics, then in such case the ceftriaxone has to be replaced with the aztreonam. And if you are dealing with the MRSA group of organisms, then you need to add vancomycin. And if the individual is having VRSA, that is vancomycin resistant Staphylococcus aureus, then you need to give, or you need to add linezolid to the above regimen. That is in severely sick patients. For suppose, if the individual is having some underlying comorbidities also, right, either diabetic or COPD, or having congestive heart failure, some underlying comorbidity is there, or there is like past history of your influenza like illness, or if there is like necrotizing pneumonia, then in such case you need to give piperacillin tazobactam, or carbapenems should be given, like meropenem or imipenem. Okay, and a fluoroquinolone should be included. Aminoglycosides intravenously should be given, or aminoglycosides plus fluoroquinolone should be added. So this is like when the individual is having an underlying risk factor or comorbidity. So this will be the antibiotics. So depending upon the severity, you have to select the antibiotic, or you have to select the antibiotic depending upon the culture and sensitivity of the individual. So this is in toto about the very important topic, that is pneumonia, right? I will be also showing you some multiple choice questions on the topic of pneumonia, which makes you the topic more easier. Thank you very much.